Hi, welcome to the office. I'm Dr. Vinton, and the purpose of today's visit is to find out what is the underlying cause for the problem that you're having in your joint. Now, the first thing I guess we should say is that we're going to spend about an hour today, so just relax. We're going to spend some time doing some paperwork. We'll spend some time reviewing your history, performing an evaluation, taking some x-rays, as well as going over those together so that we know exactly what we're dealing with. Know that we have a team of specialists with access to every standard traditional medical treatment, as well as alternative methods, who have scoured the globe and spared no expense to bring the most up-to-date, proven, and cutting-edge treatments to help end our patients' pain and avoid surgery. Our team includes 3 medical physicians and 2 doctors of chiropractic in one of the most technically advanced private clinics in the country. We help train doctors from around the world, and we have a combined 116 years of experience. Rest assured, you're in good hands. So I guess the first thing we should talk about is what is normal. So normal for a joint, and there's actually something called the Kellgren-Lawrence scale, which we'll go over, but the Kellgren-Lawrence scale defines a joint from absolutely healthy to a little bit damaged, to more damage with arthritis, to totally bone on bone. And it would really depend upon which of those phases your joint is in, as opposed to what the most appropriate treatment would be. We typically, on this end of the scale, when a joint is very healthy, standard things like therapies and whatnot of varying kinds typically do the job. Most of our patients have some form of varying degeneration in their joints, and that's why they're here, because the therapy hasn't worked. Most folks then moved on to the cortisones. So the problem is cortisone itself causes more arthritis and actually accelerates having a joint replacement. And as most people have found out after multiple rounds of cortisone, they still have their problem, or it's actually gotten worse in pain and they're not able to move as well as they could before. Because even if cortisone does its job in relieving some discomfort, what it doesn't do is protect the damage in the joint. So as a result, every step you take causes more pounding in the joint. And as the cortisone wears off, you actually now physically have more damage to the joint. In addition, one of the known side effects for cortisone is it actually pits or damages the gentle cartilage in your knee, causing it to degenerate further. It causes the ligaments to thin and shred, causing them to become weaker, causing more arthritis. And most folks are completely unaware that every injection of cortisone causes a bit of bone loss, which eventually will lead to osteoporosis. And if a person has enough cortisone, it'll actually cause the bone to melt like candle wax, and what's called avascular necrosis, it'll actually cause the bone to die. So although cortisone has its place, it is very short-term and very limited, and it by no means fixes the underlying problem. The next step that most people take is the rooster shot or the gel shot or the chicken shot. And what happens there is that is actually a synthetic lubricant, kind of like a lube job for your car, that physically lubricates the synovial fluid to try to help protect those joints as they pound together. What it doesn't do is stop the arthritis. So you have that done every 6 months to a year. And what will happen is that each time you have it, it typically works less long. So maybe if the first time you had it, it lasted 6 months like it's supposed to. Maybe the next time it only lasts 4 months. And maybe by the third time it only lasts 2 months. And the reason is because although you're getting some temporary relief, the problem is it doesn't fix the underlying reason why. As a result, you end up with more arthritis as time goes along. The next step after the viscosupplement would be something called orthobiologics, of which there are 2 divisions, factor-based and cell-based. Now, the reason it's called factor-based is because it does not contain extra stem cells, but it does contain all sorts of healing proteins, cytokines, and growth factors, and has been used for decades with great success in helping the body to repair damaged tissues and joints by encouraging your body to produce a healing cascade, including attracting and helping attach our own circulating stem cells. One kind of factor-based therapy, platelet-rich plasma, called PRP for short, which was actually kind of made a household word by Heinz Ward and Troy Polamalu during the 2009 Super Bowl. Neither one could play, and a week later they both played in the Super Bowl, and people said, how did you heal so quickly? And the answer was PRP. What PRP stands for is platelet-rich plasma. Literally, it's a blood draw out of your arm, and they spin the blood in the centrifuge, and the top layer of the blood separates into what's called the platelet-rich portion. And it's platelets that heal. So if you cut your hand, what allows your hand to heal are platelets. When they do open heart surgery, they'll squirt some PRP in to help those ribs heal quicker. What happens is the platelet-rich portion speeds up healing, it causes new blood cell formation, and it also causes degeneration to stop. Now, what it doesn't do is it doesn't grow new tissue, but what it does do is help the tissue that's there to heal. So the PRP has a big proponent in helping joints and arthritis from progressing further. What happens if a person is beyond what PRP can do is now we move into another factor-based therapy called Interfill. Contains all sorts of proteins and healing cytokines and growth factors, and has been used for decades with great success in helping the body repair damaged tissues and joints. These donated cells are from the chorion layer of a healthy donor's placenta and are called tissue allograft, which means donated tissue. Factor-based orthobiologic tissue allograft therapy has been around for many, many decades, and our doctors have been working with it for over 25 years. What happens is stem cells are what we're made of. Stem cells are primordial cells. Actually, we couldn't live an hour without our own stem cells. But as we age, our number of circulating stem cells decreases. And when we're an infant, 1 of every 10,000 cells that we have is a stem cell. By the time we're 16, that's about 1 in 40,000. By the time we're 50, that's 1 in 400,000. By the time we're 60, that's 1 in a million. By the time we're 80, that's 1 in 2 million. And what happens is if you watch a 2-year-old fall down, they jump up a lot quicker than if an 80-year-old falls down. And the reason for that is the plasticity of the tissues, which is directly related to their stem cells. So what happens is when we do an orthobiologic treatment, either a factor-based or a cell-based, it's no longer a treatment. This actually helps your body to heal and grow new tissue. Stem cell therapy only does one thing. It helps your body heal and it grows new tissue. Not sometimes, all the time. That's what stem cells do. Whatever they come in contact with, they begin to replicate and make new again. There are 4 legal places to obtain a stem cell. 2 come from your body and 2 come from a donor. The ones that come from your body actually come from your bone marrow in your hip or from your belly fat, like with a liposuction. Stem cells are made in the bones of your body. But as we age, the bone marrow in our long bones decrease production, and only our skeleton still produces stem cells well into advanced age, as evidenced by hematology and oncology utilizing bone marrow transplants to help regenerate an immune system. But as you age, the number of circulating stem cells in your body decreases. All we do is help them mobilize by taking them from an area of abundance and depositing them in an area of depletion, changing the environment inside the damaged joint, creating new blood flow, taking your body out of inflammation and into proliferation and regeneration, helping your body create new tissue and heal the damaged tissue, like it used to do when you were younger. Bone marrow aspirate used to be a painful procedure because they literally took a piece of bone out of your hip, much like an archaeologist might take a core sample out of a rock. However, new technology now allows the bone marrow aspirate to be drawn by numbing the area, and with one poke, minimal to no pain, the marrow is drawn and directly re-injected back into the damaged joint or joints, knees, hips, wrists, ankle, shoulders, spines, any joint can benefit. Notice the MRI on the left has lots of increased white, and that indicates worn cartilage. That's arthritis. Notice the MRI taken on the right 2 years later and how much less white there is, indicating new cartilage growth covering up the bone, allowing the joints to glide smoothly and easily and without pain. Once you grow new tissue, you grow new tissue. The clock starts over. It's not uncommon to rewind the clock back 20 or 30 years. Notice the X-ray on the left, and the joint space is collapsed, and all the extra white indicates wearing away of the cartilage, and again, that's arthritis. Now notice the X-ray on the right taken 10 years later, how much better the spacing is, both on the inside and the outside of the joint, how much less white there is, how much more even the coloration is, indicating increased cartilage growth, decreased arthritis that is maintained for over 10 years. Notice on the graph how both the knee replacement and the bone marrow aspirate injection both have dramatic reduction in pain and increased mobility. But over time, the bone marrow aspirate actually exceeds in decreasing the amount of pain and increasing your mobility all the way through the 15-year study. Once you grow new tissue, you grow new tissue. The clock starts over. It's not uncommon to rewind the clock back 20 or 30 years. The same goes for any joint in the human body. Notice the x-ray on the left. The shoulder joint is significantly deteriorated. And now notice the x-ray on the right, how it's been restored. Notice this x-ray of a hip. The x-ray on the left shows significant degeneration and deterioration. Now notice, after their stem cell injection, the hip on the right. The joint is much improved, much healthier, and functions like a much younger hip. Many people are unaware that of the 132 medical schools in the United States, only 6 teach an actual course on pain. On our staff, we have a pain management specialist who assists us with our regenerative injections into the spine to help heal and repair degenerated and damaged discs and joints and stenosis. Notice the MRI on the left. Above the red circle, you'll notice the discs are white and fat and plump and healthy, meaning that they're well hydrated, full of water. Notice within the red circle, the discs are thinner and they're darker and they're dried out and they're bulging and ruptured. Now notice the MRI taken on the right after their stem cell injections, how the discs are becoming lighter, indicating the disc is healing and becoming full of fluid again. Also notice the protruding herniated discs have retracted back to their normal position, taking the pressure off the delicate spinal cord and nerves, relieving pain, significantly improving mobility, and winding the clock back 20 or 30 years. These are truly cutting-edge procedures, currently something maybe 1 in 10,000 or 1 in 20,000 physicians might even be aware of, let alone be proficient in. There are a lot of factors that we take into consideration when choosing whether to use a factor-based, like PRP or tissue allograft, or a cellular-based procedure like a bone marrow aspirate stem cell injection. I often tease, if you're old and decrepit, so are your cells. If you have diabetes, so do they. If you're on multiple medications for multiple other health conditions, your doctors will take all of this into consideration in helping you decide the best course of action to rid you of your pain, help heal your damaged joints, and avoid a joint replacement surgery. Athletes 30 years ago used to go to Germany and have these things done because Germany doesn't have an FDA. And as a result, they can mix in cytokines and growth factors and other things to those stem cells at a cost of $50,000 an injection to help those things do what they needed to do. The fantastic news is technology now allows us to obtain cells that come from a donor. Because they come from a donor, they're technically called a tissue allograft because it comes from another person. In this case, they actually come from an umbilical cord. When my assistant had her baby just recently, she was encouraged to save the umbilical cord. The same with my daughter a few years ago, was encouraged by the hospital to save her umbilical cord. So should the baby ever have a problem, they can simply go to the cord bank and retrieve their own stem cells and help heal their own organs. So what happens is for mothers who choose not to do that, they become donors. And they literally go through a process all through their pregnancy of being screened, just like you would for any other organ. And at the moment of delivery, once the cord is clamped and mom is handed the baby, the rest of all that, which is typically discarded, is processed and cleared by the FDA as connective tissue matrix for regenerative healing to repair or supplement damaged tissue, including bone-on-bone arthritis. So if you're 50 or 60 or 70 or 80 years old, when we inject a stem cell into the joint, it's just hours old. Think of it like having a 2-year-old run around inside your knee as opposed to a 70-year-old run around inside your knee. So not only are they viable, and not only are they more potent and more in number, more in volume, but they also come from nature with those cytokines and growth factors. So when they're injected into the joint, they have the ability to separate into 6 different kinds of tissues, whether we need cartilage or bone growth or to resorb the arthritis or to grow new meniscus or new fluid. And as a result, that's typically what we do to help people to avoid from having a joint replacement surgery. In addition to the amazing benefits and healing power of regenerative medicine and stem cell therapy, we utilize several cutting-edge modalities to help and encourage your body to speed up and maximize its healing. Recently, the American Academy of Orthopedic Surgeons updated their guidelines for osteoarthritis of the joints to now include Class 4 laser therapy as a recommended treatment option. The same has been found with pulsed electromagnetic field therapy, with research showing its effectiveness in helping treat the symptoms of osteoarthritis.
A groundbreaking Oz. You don't have to live in agony anymore.
Inside this mat, there are electrical coils. And when electricity passes through there, it creates a magnetic field that moves through the body. And it opens up the blood vessel. It breaks apart these red cells. They're not stacked like coins. So you can get deep healing, better oxygen supply. So the healing process takes place. You don't just feel better. You are better.
Another beneficial therapy, soft wave therapy, helps stimulate stem cell production for up to 12 weeks after a single treatment.
Imagine having an injury but not needing to go under the knife or rely on addictive pain medication, yet you can be healed by shock waves. That's the idea behind something called soft wave therapy.
Now, these incredible modalities will give some pain relief and improve mobility, but they don't replace the need for stem cells to grow new tissue. But used in conjunction, help accelerate the body's healing above and beyond, making for incredible and lasting results. These are all cutting-edge technologies and are utilized by many major universities, and even the Mayo Clinic now offers an advanced regenerative medicine program.
We found that the procedure produces a viable product which has stem cells in it and can be used to inject back into the patient's knees on the same day that they're harvested. We designed this study as a very early test of safety and feasibility. Stem cells are the building blocks of many types of adult human tissues. They can go on to form things like bone, ligament, cartilage, things that make up the joints in our body.
Let's talk about a joint replacement surgery. Folks are often unaware that even after, let's say, a knee replacement, half the people still have pain. Of an average on a scale of 0 to 10, of an average of about a 3, and as high as a 5, depending on what activities they're performing. So even after the surgery, their pain ranges from a 3 to a 5 out of 10 on a daily basis. So the pain doesn't go away. The second part is all the trauma that happens from having the knee replacement. 6 to 10% of people get the infection. Now, the infection can last weeks or even months. I've seen it last years. And as a result, during that time, you're unable to do your normal daily activities. The second thing is that with the joint replacement, you're going to have 3 to 6 months of physical therapy. Your knee is going to be constantly, let's assume it's a knee or an elbow or shoulder, will constantly have a bit of numbness to it, and it may or may not regain its full range of motion. And it always feels just a little bit different because it is. It's a titanium or a metal implant. So the reason that stem cells have become so popular, in the year 2000, 90% of people had the joint replacement. Only 10% had the injection. By the year 2015, that was 70-30. 70% had the knee replacement or the joint replacement, 30% had the injection. The prediction is, in the near future, that'll be 90-10 the other way. And the reason is because people get to keep their own joints. They don't have the long recovery time. They don't have the risk of all the infection. And once it's injected, other than maybe taking it easy just for 72 hours, there really is no downtime. Most people historically have the pain relief they sought by the 30th day. As that tissue continues to regenerate, as month 3, 4, 5, and 6 go along, the vast majority of people are able to do the task that they want to do without the pain or limitation. Stem cell will continue to heal for up to a year. So when we do a reevaluation at the 6-month point, we typically see the joint space opening up. We typically see the arthritis resorbing. We typically see roughly 20 to 30 years worth of damage being peeled off of that knee. And folks are happy because they can go on and enjoy their life. And the key thing is they can keep their independence. They don't have to burden their family with helping them get around, whether it's from having a joint replacement or, heaven forbid, they had an infection from the joint replacement. And the key thing with joint replacement is folks don't understand, and doctors often don't tell them, and it's the third most common reason people come to see us. 1 in 200 develop a blood clot after a joint replacement within 30 days. So the idea of being able to regenerate that joint and be able to keep the parts that God gave you, to be able to keep your mobility and independence, and not become a burden to your family is a huge reason that that pendulum is swinging to, like we said, that soon it'll be 90% of people just have the injection and only 10% for whatever reason will have the joint replacement. Now, all of this is based upon that Kellgren-Lawrence scale that we spoke of just a moment ago. If we have little to no damage, then yes, therapies and things tend to work just fine. If we have a grade 2 or a very early grade 3 damage, then the visco supplements lubricate and do just fine. PRP also works well in that category. Now, stem cell can be done anywhere along this path, but especially as we move into the mid to late grade 3s, where there's significant arthritis in the knee. As long as there's any space left, the stem cell will work. If it is totally bone on bone, and I need to say something about that just because I talk to hundreds of people every week, and every one of them, their doctor tells them that they're bone on bone. In reality, when we actually do the exam and take the x-ray, less than 4 to 5% are actually bone on bone. Most are a mid to late grade 3. There's significant damage, but there's still plenty left to regenerate with the stem cell. So what I'd like to discuss now is what normal and abnormal look like, because in a few minutes we're going to meet and begin your evaluation and take your x-ray. And what it really comes down to is real estate. It comes down to how much damage is done to the joint and what's left to work with. What I'd like to show you is two things. The first thing is when we take a look at what a healthy joint is. In this case, it's a knee, but a shoulder or an elbow, they're all pretty much the same. The bone above and the bone below have cartilage on them. We think of cartilage like Teflon on a skillet. Think if your Teflon is nice and smooth, your eggs slide right out. And if we have the meniscus, which are the spacers, we have ligaments that wrap all around and hold it into place. And what happens is around the whole thing is a giant water balloon. And in that water balloon, it's actually a joint capsule or a bursa sac, we call it the water balloon, is the synovial fluid. That's what lubricates it. Now, synovial fluid is thick, like an egg yolk. And what happens though is when you get arthritis is it thins out more like water. So what used to cushion every time we take a step or every time we move a joint no longer cushions and the bones begin to pound. And what that begins to do is that begins to cause damage to the cartilage. Much like if you scratch your skillet with a fork, your eggs don't slide out as easy. The same thing happens to the joints. They begin to creak and crack and maybe not move as well as they used to. That then causes more pounding, and that pounding begins to damage the meniscus. And to self-protect, the body starts to lay down more bone, kind of like a spot weld to try to protect itself. That's the arthritis. And as the bones get closer together, these ligaments, which are usually tight, they begin to sag. And what that allows is every time you take a step or every time you move, the bones rub even more. And that's how the arthritis promulgates. So what needs to happen is we need to inject something into the joint to stop that process. As we said, the visco supplement, if it's an early grade of degeneration, can help lubricate it and stop it from pounding. But once we have severe arthritis, that will no longer work. That's where stem cell therapy comes into play because it will literally help to regenerate the cartilage. It'll literally help the body to resorb the arthritis. It'll literally help those joint spaces to open up. What I'd like to show you is an x-ray of a patient who chose not to take our advice and continue to have cortisone injections, even though we explained, as bad as that is, if we take a look, we'll see that there's very, very narrow joint spaces. We'll see a lot of bone spurs. And with that, even though that's a strong grade 3, she's a prime candidate for what we do. But by having cortisone and allowing those bones to keep pounding, and this is something that many people don't quite get, is the idea that when we have a lot of space, there's cushion. But the more degeneration there is, the less cushion there is, and the more pounding there is, and the more that happens, the faster the arthritis accelerates. And in her case, she said, I'll call you when the cortisone no longer works. She called us about 8.5 months later, and we took another x-ray. And in that particular case, her bones had already fused. There's nothing more could be done. She was now forced to have a double knee replacement, which she did not want to have. And she didn't understand that her knees could degenerate that quickly to where they completely fused together. Now, conversely, this next image is of an 88-year-old man. He had a surgery on his right knee, said it was so horrible he's never going through that again. And you can clearly see the outside of his knee has plenty of space. The inside of his knee is not quite, but almost bone on bone. Because he did not want to have surgery, and that's a very tough case. That's like a grade 3.9 out of 4. It's not fused, but it's pretty close to being fused. We went ahead and did his injections, and we took an x-ray 4 months later. And as you can see, although not perfect, it is substantially better than it was. There's probably 5 or 6 times more space in his knee because that tissue regenerated. So what happens is we have the ability, science and technology now give us the chance to begin to reverse that damage pretty much anywhere in your body so that we can delay or prevent from ever having had the surgery and the complications that go with it. In addition to choosing the finest quality of tissue allografts or stem cells, the next most important thing is making sure that the injection actually gets inside the joint. It sounds crazy, but 85% of physicians do what's called a blind injection. They literally just kind of feel and then stick the needle. The problem is, in a knee joint, they miss the joint 25% of the time. And the tighter that joint is with arthritis, the more chance they have of missing. Shoulder joints, on average, are missed 55% of the time, just because it's a blind injection. Now, 10% of physicians will use an ultrasound and literally guide the needle as they go. 5%, like a surgeon, would use a fluoroscope. Now, a fluoroscope is a motion x-ray. It allows us to see directly inside the joint. So first we use just a little bit of dye, and as we inject the dye, when you hit the joint, you'll see it fill in on the computer screen. Once you know that you're in, you can unscrew the dye and screw in the injectant. And when you inject, you actually watch it fill in so you know that you have 100% placement. And that, in addition to the highest quality of tissue allografts or stem cells, plus the proper follow-up, allows us to have the highest potential chance for success to restore the damage in your joints and allow you to return back to the things you enjoy doing most. Now, I do need to tell you that for most people, they like to talk about what their insurance will and won't cover. I will tell you, for a starter, there is no charge for today's visit. We never have in over 30 years. So just relax. Let us get through what we have to do with the exam and the x-ray so we can have the information we need to have an intelligent conversation. Now, once we take a look at the amount of damage, if it's a grade 1 or a grade 2 or even a very early grade 3, the visco supplements will work just fine, as well as will some therapy, maybe a decompressive knee brace, and your insurance covers most, if not all of that. But if, as many of our patients have, it's a mid-grade 3 already pushing in towards a grade 4, I have to tell you that insurance does not cover PRP and does not cover stem cells. In fact, surgeons are fighting like crazy legislatively right now to have that not happen, because they get $60,000 for every joint they replace. The average surgeon does roughly 5 a day. So that's a lot of income, and that's a lot of lobbying power that's working towards having stem cells not be covered by insurance. So even if what is required to correct your problem is beyond what your insurance would normally cover, breathe easy. We offer multiple payment plans from different companies that have payments as little as $20 a week. And we find that most people can fit that within their budget, regain their health and mobility, and continue to enjoy the quality of life that they've always enjoyed without having the limitation of pain, and they can get back to the things that they love doing most. What I will also say, and this is part of what allows us to have the success we have, is we're going to do a full body examination. So in just a few minutes, when we examine, we're going to examine from the top of your head all the way to the bottom of your feet. It's all connected. So we know for a fact that if we have a dropped arch, that it can cause a torquing in the knee. We know for a fact that 30% of our patients will have stenosis. They don't have any back pain, but there's closing off. Just like you don't feel an artery clog until you have a stroke, they have their lower back or their neck begins to close off and the holes get smaller and pinch the delicate nerves that go down through your knees on their way down to your feet. And so we'll find 30% of our patients will actually have stenosis that's causing their knee pain. 20% of people, as the first sign of sciatica, have intense knee pain without having back pain or leg pain. So just relax, this is what we do, and as we do your exam, we'll uncover these and we'll explain it all as we go. We'll take x-rays as is necessary, and if need be, we'll order an MRI, but we'll go over all of that information together so that you feel comfortable and understand thoroughly what it is that we plan on doing and what type of results and or risks we expect. The great news is, though, because we use such conservative methods, the risks are very, very minimal, and our staff performs everything in a sterile environment. You are numbed beforehand, and you're able to drive yourself home, so that is numb it locally, so that you feel very little, if any, pain, mostly just a little bit of pressure. And the great news is usually after 72 hours, you're back up to full speed doing whatever it is you normally do. So I'll be with you shortly. And the key thing that we're looking for is how much real estate is there? Is it a grade 1, 2, 3, or 4? And that will determine what we can and can't do. And it'll also determine what will work short term, but more importantly, long term for you, so you can get back to doing the things that you enjoy most without the limitations of pain or limited mobility.